Thanks.
Thank you.
You're live now, Aisling.
Thanks, Anya, and good morning, everybody, to all our colleagues here on this November bleak day. But I promise you that the next hour and a half will be far from that, because it's my great pleasure to welcome Angela Colkman and Sheila Wickham this morning to our session on behalf of the RCSI and PNA Faculty of Nursing Midwifery and the PNA programme. Today's webinar is the first of 3, actually, which deals with matters relating to physical health, mental health, screening, metabolic syndrome, and the colleagues who are presenting today. I have the pleasure of knowing Angela almost, I won't say how long actually. Sheila I've met recently, and we had a discussion way back in March in respect of some of Sheila and Angela's expertise in the matters of screening, metabolic syndrome and physical disorder. And little did we know that how relevant and prevalent some of the issues are coming to the fore again here in November. So without further ado, on behalf of the PNA, and my thanks also to Catherine Klumovani and Anya Halligan, who are working with us here in the RCSI, it's my great pleasure to introduce Angela Colkman and Dr. Sheila Wickham. Thank you.
Thank you.
Morning, everybody. Just before we put Sheila and Angela on, I'm Catherine Klumovani, and I'm just going to tell you a little bit about them. So Angela is an associate professor and lecturer over in the School of Nursing, Psychotherapy and Community Health in DCU, where she's been for a number of years. She holds her PhD, she has a master's, and she has a BSc, and she has huge expertise in the area of best practice in the screening and monitoring of individuals for metabolic syndrome, and she's also a fellow of the faculty, so we're always proud of that. And her colleague today is Dr. Sheila Wickham, and Sheila has a lifelong career in the care of patients with diabetes. She holds a doctorate in nursing science, the MSc and an MSc. She's a diploma in family planning. She's a diploma in diabetes. She's also a fellow of the faculty. She's an RGN, a registered midwife, and a registered nurse tutor. And at the minute too, she's also an associate professor and lecturer in the School of Nursing, Psychotherapy and Community Health over in DCU. So we're absolutely delighted to have them here today to share their expertise. So just in terms of the format of today, Sheila and Angela are going to try and have a kind of a little bit of an interactive session with you. They're going to ask you questions and things, and you can use your bar. You have a questions and answers box on generally on the right hand side of your screen that you can reply, and they will see your answer. So we really would ask you to engage with that, please. It makes life much easier for us sometimes when we're teaching, and again it breaks up just the monotony for you as the attendee. There's 31 of you on already, so I'm conscious that the numbers are just rising there as an odd one attends. Anya has put a link to the MS Teams. It's a form that if you would like your cert and the slides sent on to you afterwards, for your credit for NMBI, just pop your name and your email into that, please, because we don't know who's on unless you tell us. So as soon as the session is over in the coming days, we will pop on, send on the cert and the PowerPoints to you. So without further ado, it gives me great pleasure to welcome Angela and Sheila to the session. Thank you both.
Thank you.
Thank you, Catherine. We'll let you start, Angela. If you like that.
Okay. Morning, everybody. We're going to start. We have 3 sessions, as Catherine has outlined, and this morning's session will be specifically on screening for metabolic syndrome. I'm taking the lead on this more than Sheila, because we'll be back here again in another week and we'll be looking at chronic illness and more about diabetes, and that is more Sheila's area of expertise. So I'll take the lead on today, and Sheila will just help out on some of the slides, if that's okay. So we're going to give a background information to really what this is all about. I mean, what are we screening for? So we need to know exactly what is metabolic syndrome. And I'm going to talk a little bit about the prevalence rate, the amount of metabolic syndrome that's in our population of clients. Sheila is going to go on do some slides to do on specifically the importance of screening and a lot about disease prevention. And then when we talk about prevention, then it'll move back into the best practice for screening and for monitoring. And I'm going to give time at the end, and we also would like you to interact with us. Now, Sheila will be watching the Q&A, so that, you know, if you can interact and if we can find out maybe where you're at or whether you're using a metabolic monitoring tool, we'll ask a few questions as we go, so we'll have an idea of what your needs are, because we want to kind of tailor these talks specifically to what you need rather than what we want to give you. So we're going to start by talking a little bit about, we have a problem, okay, and I'll always start with the problem is that people with, particularly people with severe mental illness, they seem to die a lot earlier than the general population, and we call this premature mortality because we don't expect everybody to be dead in their 50s and 60s. We expect now, with lifespans extending over 80s and well into the into people's 80s, that people would live that long, but we're finding more and more that people with mental illness are dying up to 25. Anything from 15 to 25 years. And the reason for that increased mortality, now I wish I had time to go through every one of them. There's a lecture on each one of these. If you can see all the little boxes around increased mortality, you can see there's a lecture in each of these. But we can only deal in our slides really in the next couple of sessions with metabolic syndrome and diabetes, because we know that is one of the leading causes of mortality. But we also know other things contribute, like diet and exercise and the increased obesity. We have still problems with tobacco smoking in our clients. We have less adherence with medication causes all kinds of issues. We have inadequate screening and diagnosis of physical health problems. That is a big issue for us. I'll deal with a little bit with that today. We'll talk slightly about that. We will also talk about this poor quality and access to medical care. And we'll talk a little bit about diagnostic overshadowing because that fits in there. We mentioned antipsychotic side effects, but that's another lecture. That's a huge area of pharmacology, looking at antipsychotic side effects. So basically our slides will touch on some of these areas because they are important and they lead to a lot of disease and mortality among our clients. But specifically today, it's always going to be about metabolic syndrome because that's what we're screening for. So what is metabolic syndrome? It's called MET-S in some of the articles. It's a group of risk factors that come together to make the client more vulnerable to things like cardiovascular disease, diabetes and stroke. And it sometimes can be seen in the literature as syndrome X, cardiometabolic syndrome, you might see that in some of the articles, insulin resistance syndrome, because we know it's linked with diabetes, and this metabolic syndrome. So it's a kind of a combination of names, just generally about the same thing, which is metabolic syndrome. The definition for it will also, to screen for somebody, and we'll be talking a lot about this later on, to screen for somebody, we're looking at central obesity. So we're looking at elevated waist circumference. We're looking for something to do with cardiovascular, and we'll always look at high blood pressure in regards to cardiovascular problems. We look at fatty tissue dyslipidemia, which is increased cholesterol. And again, Sheila's area of expertise will be the high fasting blood sugars, which probably will predetermine a lot of our clients for type 2 diabetes. And we know that any three of these big risks will contribute to somebody being diagnosed with metabolic syndrome. So it's having three risk factors. That's what metabolic syndrome is. It's three risk factors that lead the person vulnerable to anything that can cause mortality, which could be cardiovascular, strokes, even diabetes. So that's basically where we're coming from. The definitions we use will be all from the literature because we do always refer back to the literature when we're looking for evidence. And the evidence here, the worldwide definition that we will be advocating that you think about and use will be the one by Alberti et al. And they give a good definition, which we'll go through in a few moments. So that's what metabolic syndrome is. So to get it into your head, it's not one thing, it's a group of risk factors that come together to make a person more vulnerable to comorbidities and then ultimately to high mortality. And that's what's causing the death rate to be 20 years younger in our population of clients than the general population. There's a prevalence there. I've been looking at this now for at least 10 years, and I've been looking at literature, both from Ireland and overseas, and the prevalence is really high. You know, 30% of our clients, up to over 50% of our clients have metabolic syndrome. And these are the ones that we've looked at. These, you know, there's probably a lot more, but we know, dating back from the Katie study, I think a lot of you might be familiar with that big study that took place in the in the 1990s. It found 30% of the population had metabolic syndrome. We weren't even looking at metabolic syndrome, they were looking at different medications, and they were looking at efficacy of medications. But then later on they went back and they found, with their military veterans who were on a lot of antipsychotic medications, and found over 50% of them had metabolic syndrome. Same in Denmark, over 54% of those patients had metabolic syndrome. The best country that did the best out of this was Finland. They were saying that only 37% of them. So we're going from 30s up to the mid 50s. I did a small study a number of years ago here in North County Dublin with, maybe some of you might have heard of it. It was a little study with one of our students that worked with me at the time, called Darren Gallagher, and we found the same thing. We found actually very high rates in the Dublin population, up to 60% in some of our clinics that we looked at. And, you know, most of those patients were all with severe mental illness, all on antipsychotics, and, you know, the amount of metabolic syndrome that was present at that time was quite high, and it hasn't really changed since, because a very recent study last year found the very same thing: high rates between people who are on clozaril and people who are on long-acting injections and people who are on just oral antipsychotics. We're still seeing high rates of metabolic syndrome that are being detected. So, you know, it's definitely an issue and a problem for us. And the more of these patients, if 50% of our patients have metabolic syndrome, what does that mean? It means that 50% of them may not live over the age of 60, which is very, very frightening and very, very worrisome for us as care providers. So, you know, it is a big problem with increasing mortality. Okay, so we know that physical health results in adverse effects from medication. We know that. I'm not going to go into that. We know that that leads to increased rates of obesity. Yeah, and we know that this can directly affect cardiovascular systems, immune systems, and nervous systems. We know that because that's one of the things that comes out well out of the literature. We know if we look at eating disorders, we know the effects of eating disorders and self-harm. We know that that can increase mortality with electrolyte imbalances. We know that there are high rates of very unhealthy behaviour in a lot of our clients. We still see a lot of smoking. We see a lot of drug and alcohol abuse now, in more than ever in our young population of clients with drug-induced psychosis. We see not a great motivation or an ability to manage physical health conditions. It doesn't seem to be highlighted as a very, very big issue, and it's coming up maybe more and more now, but over the last 10 years it hasn't been the biggest issue. It's been more recovery focused and, you know, service user involvement than it has been to motivate physical health and physical, you know, to seek to provide more diet and exercise programs. We see a lot of problems too with clients or patients accessing physical health care, and that's sometimes to do with stigma, but most important, and I know that Michael Nash in Trinity brought this up many, many years ago when he talked about diagnostic overshadowing. It's been around the literature for a while, but how important is it for us, and how prevalent is diagnostic overshadowing? I've tried to look at the literature on it to see what the literature is saying. If we want a definition for it, it's really physical complaints undiagnosed, not being picked up by people in A&E or by GPs and labelled then as psychosomatic, or they're just anxious even though they have chest pain, or you know, there's something else going on. So this term has been around. It was first used in 1982 by some medical people who noticed that these physical problems of the patient with psychiatric illnesses were being misattributed to their mental illness and not to the physical complaint that they come in with. There's a couple of studies. There's one there from America. This was a study by Sullivan et al. And they looked at discrimination in healthcare about diabetes. It was patients who had both diabetes and mental illness, so comorbid diabetes and mental illness. When they presented at A&E departments, they were less likely to be admitted to hospital for their diabetic complications than those who had just the diabetes on its own. So they were told it's part of your mental condition, you know, you're better off go back home. So they weren't really being seen as suffering from diabetic complications. And in the UK, again, UK authors also found that people who were presenting in A&E, the same problem was with cardiovascular risk. They were less likely to be screened. They were told, oh no, it's just anxiousness, you know, so you're less likely to pick up on, you know, cardiovascular problems or issues that might be happening for that client. So big issues there. There are other articles there that still talk about the diagnostic overshadowing, and it's still a big problem for us. And that's one of the areas that we need to be constantly harping on about with our clients, that they bring a list of their actual complaints when they're going forward to primary care, that it's very clear what's wrong with them and it's not going to be attributed to their mental illness. Barriers, again, when we talk about barriers, that's one of the barriers, diagnostic overshadowings. There's other barriers, and the literature talks about this fatalistic attitude that some healthcare providers have. We talk about healthcare providers saying, oh, it's no good trying to get them to stop smoking, they've been at it for years. And that's seen as therapeutic fatalism. And the literature does pick up on this now in recent years and says that it's very, it's an attitude that health providers maybe have, maybe not just primary care, but ourselves as well as secondary care providers, that we view the client as, sure, it's the only comfort to have, you know, let them have it, you know, rather than challenging that and saying no. And we also, when we looked at the literature, particularly this particular article that I've highlighted there, this one talks about clients' attitudes are not being challenged. We don't challenge them. For instance, the client might say, what's going to happen is going to happen. It's no good in worrying about it. So they have this attitude, well, I'm going to get worse anyway. So they're not even, you know, trying to do something about it. And then someone will say, oh, it runs in my family. There's not much I can do about that. You know, accepting the fatalism of whatever illness they're going to get or have already got. What's done is done. Yeah, and this one is about smoking. I don't know if quitting smoking will really ward off the risk of cancer. So they're not even thinking that if they give it up, that they might have a better chance of life. And others then would say it's God's will that I'm sick. You know, there's nothing you can do about it. So basically, these kind of attitudes really is something that we need to challenge. Patients' attitudes, because you know, we're running the risk here of accepting this therapeutic fatalism, both with the patients being fatalistic and with us as professionals being fatalistic. And the truth is, they do want help, and when they realise, you know, that they have developed some sort of chronic illness, they are willing to work with us and do something about it. You know, and some would say it's not my fault that I'm sick. This could have happened to anyone in my situation. So we have to challenge those kind of attitudes and say, no, hold on a minute, let's look at a better way forward. And when Sheila talks about the importance of, you know, how we screen for chronic illness, you know, we'll bring back this thought to you that you can think, well, what can I do as a nurse to challenge these thoughts and to change the patient's attitude towards developing a chronic illness, which we know a metabolic syndrome is once you develop it, but we can turn it around. When we're looking at the evidence also, we do look at a lot of evidence when we're talking about the importance of, you know, health promotion and helping clients. And this particular one is Quality Research Article 2018. This one looks at they're looking at higher mortality rates and reduced life expectancy in people with mental illness, right? So they did interviews. They did interviews and they did surveys with people who provide care like us. And then they did interviews and surveys with the patients themselves. And they had a mixture of patients with bipolar and schizophrenia and major depressive illnesses. So, you know, we're really trying to find out here to understand what are the barriers to health promotion, or what beliefs people had, okay, about doing something about their health, because we know there's no point in screening for a chronic illness if we're not going to be able to change the person's perspective on it or do something for them. So interestingly, half of the clinicians who were surveyed and interviewed believed that patients with mental illness cared less about preventative care than the general population. So that's a big challenge for us, that half of our clients believe there's nothing much we can do. So that's not good from the point of view of nursing care and preventative medicine and moving forward. Yet, look at what the patients' attitudes. 88% of them reported an interest in improving their health. So what does that tell us? You know, there is a big divide between what clinicians think and what patients think. And clinicians definitely have that fatalistic attitude, even though, you know, it's highlighted when you look at the literature that the clinician believes, they don't really want to do anything. They're not interested, whereas we know the clients themselves do. So the results from this would indicate that we can help patients a lot with preventative, with health interventions, with improving their health, improving health behaviours, in better collaboration with them, in setting goals that are very realistic for them, and giving them a chance to bridge that divide between the comorbidity that they have and hopefully decreasing that mortality rate that we talked about. We don't want 60% of our clients, having premature deaths due to mortality that can be turned around and changed, because we know we can help with type 2 diabetes. We know we can help with cardiovascular disease and asthma and all of the chronic illnesses. So, this is important for us. This is huge evidence for us to look at the literature and see what is the problem and what we can do about it. Now, Sheila is going to come in and Sheila is going to talk to you more about screening and disease prevention.
Good morning, everyone, and thank you, Angela. It's good to hear and have a chance to chat with you today. As I say, Angela and myself have been doing these sessions on a few occasions, and we do it because we're very passionate about this topic. Now, one thing we would normally do is get everyone to introduce themselves and say where they're from, which obviously in this sort of event, because it's online, we can't do. But certainly, we would ask that you use the live event Q&A. If you have any questions, or if you want to raise a point, we would always say people learn as much from each other on these sessions as they do from Angela and myself chatting. So please use the Q&A. You can put your question in or your comment in at any stage. I'll be watching it while Angela's talking and vice versa, so we can raise them then as we go along. And as I say, thank you, Claire. I see there's a question in already in relation to sports screening. We'll come back to that a little bit as we go further on in the session. Now I'll start with screening and we'll answer that then as we go further on, but that's ideally we want to see little interaction, because we, as I say, we're very conscious the expertise and wealth of knowledge that all you have is partly what helps us with our work in relation to this. As I say, Angela and myself come from slightly different backgrounds. We met together in DCU and we found it fascinating that we had such a common shared interest. Having worked in diabetes, I used to find it very frustrating and annoying that I had patients sick and dying from conditions that could have been perhaps prevented or at least better managed and reduced, therefore the instance of problems reduced. And Angela felt the same way. Now today we're going to talk mainly about metabolic syndrome. Next week we'll be talking about diabetes, and our third session we will talk then about how we can actually prevent it. Talking about screening, it's interesting, and Angela mentioned this unconscious, the fatalism and that we have, and quite often I would argue it's unconscious among any of us. Like how often I would hear my patients referred to as diabetics, or you would talk about your psychiatric patients perhaps, or mental health patients. They're not, they're actually people with diabetes or people with mental health issues, and it's something I think is perhaps important that we raise that. I see Angela's screen is gone.
Sorry.
Are the slides gone, or would you want me to share, Angela, or do you want
no, I can put you back. You're back now. Sorry about that.
The screens are back up, because it starts with the diagnosis of, the next slide is a definition of what screening is, and it refers to the use of simple tests across a healthy population in order to identify individuals who have disease but do not yet have symptoms. And it's interesting, it's to some extent we need to talk about what the concept of health is. Just because a person might have a chronic illness, such as a mental health issue or diabetes, doesn't mean they're not healthy, and doesn't mean they don't need to be screened. And that's something we need to, the diagnostic overshadowing will often knock off the main picture. You know, it's people with diabetes or mental health issues, they'll only screen for specific things like a worsening of their condition, but they wouldn't routinely think it's important they go for screening, even the screening that's available in this country. And we screen for a number of conditions routinely in Ireland. You're entitled to your cervical screening, your breast cancer screening, your bowel screening now, and if you have diabetes, for your retinal screening. But how many of you would have been aware of patients going for those routine screening tests? Some would, but would all your patients, do you think? Because if you actually look at the results in those screening, people with mental health issues don't tend to attend as well. And just moving on to the next slide, why do we screen? And the whole idea is to identify the population most at risk and most likely to benefit from early detection. And that's why we talk, and Andrew will go on further into the screening for the metabolic syndrome. People with mental health issues are very likely to get metabolic syndrome. There's a very high incidence of it. So if we screen for it, we can pick it up early and ideally prevent or reduce the incidence of problems developing further and manage the illness. And that's the disease. That's what we want to do. And again, you have to think back in your own practice area, how much screening is going on. And the problem is, it's not enough to screen, you obviously have to intervene then. And again, there's something Andrew will talk about a bit more about it. We acknowledge we can't screen for everything. And unfortunately, in this day and age, we are always quite bound by finance and whether we like it or not. But the thing is, what we always have to do, and as nurses, I feel we always have to advocate for our patients so much in this area. And I will fight for screening to have it done routinely. And I do that. You consider diabetes, as I say, which is a particular area of interest. If I screen properly for diabetes, never mind metabolic syndrome, and if I catch it early, I can perhaps prevent it developing and certainly prevent the complications. And if I do that, think of how much I would save. And that's why I always am fighting to get better finance to help and to stress the importance of screening. And it's something we, as a group, as nurses, constantly have to fight to get our patients screened. And we have to believe in it. And if you look, as I say, working with your patients at the moment, how many of them are screened for diabetes on a routine basis? You may know some of them have it. How many of them are regularly checked or screened for complications of their diabetes? And this is what I mean. We have to get it to be part of our culture, part of our routine work, that we are constantly doing this because it's so important with it. As I say, we talk about what a chronic disease is, or we talk about chronic diseases are non-communicable diseases. Unlike our current COVID, which is very communicable, our chronic diseases are non-communicable diseases are ones that last for at least 3 months or more, and we don't pass them from one to the other. They're not contagious as such. They generally can't be prevented by vaccines or cured by medications. But the thing is, they don't disappear. What they can be is managed by medication and care, and that's a very, very important part of what we do with it. So the main ones we talk about, and when we talk about non-communicable or chronic diseases, which mental health is in its own right and is increasingly getting recognised, but by and large, we will talk about the heart disease, stroke, cancer, diabetes, and chronic lung disease. And together they kill about 70% of people worldwide. And that's a huge population. When you think about it, think of your patients. And unfortunately, we are finding there is an increased number of people with mental health issues who are, the proportion that we are losing is above 70%. And again, we're back to the fatalism. Oh, well, sure, they've mental health problems. I can't take the cigarette off them. It's the only pleasure they have. Yet if you'll actually talk to the people with mental health issues, quite often they are interested. If you like, it's perhaps something to do with control. I might have mental health issues. I might be limited in how I can manage those, but I might be able to manage my cigarette smoking. It's one thing I could get a grip on. Or I might be able to manage exercise. I might be able to do that a little better. Not every time, but it is something they can sometimes get a handle on and get control. And that makes them feel overall, to make them feel a lot better. And that is a very, very important part of what we do with them. So it is important that we remember that and work with them always on it. As I say, I've said the 4 main types: heart disease, cancer, respiratory disease, and diabetes. Now, if you look at those 4, things like being physically inactive plays a huge part in worsening any cardiovascular disease, or indeed in diabetes. It actually has been shown if you are overweight, which comes with sometimes being physically inactive, you are much more prone to cancers. Obviously, the harmful alcohol, which increases, contributes greatly to weight gain, and also to cancer. They're all interlinked. I can't separate one and take it out. They are all so interlinked. People with diabetes are much more prone to cardiovascular disease, people with respiratory disease. And the fact that they are all interlinked, what we try and do is, one, we try and prevent them where possible by being healthier and eating better and reducing smoking. And think what that would do for my metabolic syndrome if I could get all those in, because that would reduce my incidence of diabetes, reduce my incidence of cardiovascular disease. And all these are factors within the metabolic syndrome, which Angela is going to return to shortly. People with diabetes tend to have, people with type 1 diabetes don't have insulin, but people with type 2 diabetes have large amounts of insulin in their system, and they are insulin resistant. Again, part of my metabolic syndrome. They're all interlinked. What we need to remember about people with chronic disease, and I've said it already, just because you have a chronic disease doesn't mean you're not healthy. You can have a chronic disease and be healthy, but what you have to do is manage and care for the chronic disease, whether that's your mental health issue, your diabetes, your metabolic syndrome. Our chronic conditions, our non-communicable conditions are on the increase. And as a result, they are impacting on healthcare. We spend about 30 million a year on people with diabetes in healthcare. And the thing is, unfortunately, it's what wakes people up to the need for looking after it and ideally preventing it. But it is on the increase. We are becoming more overweight. You appreciate now how we recognize much more mental health issues. People are much more stressed. This whole instance, the lockdown which we're living through at the moment, the impact it has on mental health, the fact you are limited in your interactions with your patients and your clients at the moment. This all contributes to the chronic condition, and it increases the need or the challenges sometimes for managing it. And the thing is, we have to be, one, aware of these. We have to see what's working. There is a huge issue with lack of coordination for people with chronic disease. As I say, I would look at my patients with diabetes. A lot of them have mental health issues. You look at your patients with mental health issues, a lot of them have diabetes. How often do we ever talk to each other? How often is there coordination of that care for people? And the same applies with the metabolic syndrome. They are seen for their physical, they need to be seen for the physical care, but how often do the people seeing them for their physical care talk to the people who are looking after the mental health conditions? And it's a huge issue, which we need to work on. And this is where it's you and I, it's the people on the ground, the people who are looking after those patients. Sometimes it's simple. You can pick up the phone and ring the local centre or the GP or the practice nurse where they're attending and talk to them. And ideally, if you do that, try and set up some formal system, because we never like systems that are dependent on one proactive person. Ideally, you set up a system that it becomes routine, even just reports. When was the last time you got a HbA1c on your patient with diabetes? To give you an idea of their care. Or how often do you know what medications are changed, medication changes they're getting? It should be routine, but quite often it's not. Yes, maybe the doctor got it, but you don't see that form perhaps, or you didn't see that letter. It should be coming to you because you're the one who's dealing with the patient on a day-to-day basis. And unfortunately, it's something we're going to have to fight for and chase to make sure that we do actually get it. People with chronic diseases, whether it's a physical or mental health issue, quite often have similar challenges in managing it. Now, you know, and again, I'll be talking at further sessions about the HSE program now for patient management of the chronic diseases, and now we're encouraging that. But it doesn't matter what the chronic illness is, quite often managing it on a day-to-day basis is normal. How often do you get frustrated with anything yourself? And look at, and even if it's not a chronic disease, even if it was only that plan to get out and exercise more, we start off great intentions, and how long does it last? And the ability is when we lose that, what we're doing, that we have the ability to start and step up again and start off again. And that takes support and encouragement, which we need to give them. Ideally, we want patients to take responsibility. Now, you appreciate with your clients and patients, that's going to vary how much responsibility they can take. But it's amazing how people will rise to even a little responsibility. And it makes them feel better that they've, as I say, they've some control over some aspect of their life, be it giving up cigarettes or whatever. And it makes such a difference. The more we can educate the patients, the better it'll be. And metabolic syndrome is a case in point. It's an example of a chronic disease. We can identify it by screening. And once we identify it, then we can intervene. And I'm going to hand back to Angela now to talk more about that. And Angela, there is a question here about, is there evidence to support screening and monitoring of older people for metabolic syndrome in psychiatry of later life? Now, I know the answer to that is yes. And I think you're probably the better one to identify the sessions. So I'll hand back to you now, Angela. And as I say, queries and questions, please put them in. Or as I say, even a comment or share an experience you've had, because it's learning from each other is so much good. It's so much better than just learning from us. Thank you. Off you go, Angela.
Thank you, Sheila. Thank you. The question about elderly people, again, Sheila's dead right. It won't matter across the population whether you screen for adolescent or middle age or elderly age. It's for everybody. I've read a few articles recently about the use of antipsychotics in child psychiatry and the need to screen at that level, and I was quite surprised by that they were looking at 16, 18-year-olds that they were screening for metabolic syndrome. So it certainly is starting with the younger population and working right through up onto old age psychiatry. So yes, definitely the answer for that would be screen at all ages, right up, irrespective of age. I have two documents there, and I know that Anya, who is helping to organise these seminars, will, if you send her your email address to her, will make these documents available. If we get a chance, I'm hoping I'll be able to open both of them before the session ends. One of them is the HSE physical health assessment that they are using. It's a 5 or 6 page document, and it's good because it involves a lot of what we call the MEC, the use of making every contact count when we're interacting with our clients, and it's really good for getting all that health information out there. And the other document is a WHO Pacific management of physical health in people with mental illness. So both of them would be key documents for you to use and to be able to refer to when you're when we're talking about screening and monitoring. Okay, so I know that Sheila said the screening is very important across a healthy population to find out who has disease and what's happening in their lives. We also talk about not just screening, intervening. I was lucky enough about 3 years ago to go to a seminar, and we could go to them, to a mental health, physical health seminar, and David Shears came over from the UK. And he published this paper about the importance of not just screening, but also intervening, because he had from some personal experience that he shared with us about his daughter who was suffering from mental illness. And even though he was a GP, he found that the screening that took place wasn't followed up by any interventions, and he talked about the importance of not just screening, intervening. So that might be another article that you might wish to read and see, what exactly does he mean by that, and what is he offering in advice for patients. And specifically, it's around the area, of course, diabetes and cardiovascular diseases. So that might be worth something keeping in mind. Back to the harmonising statement again. You heard me mention Alberti et al. This would be the international best practice. It's across the world. Most people who are screening for metabolic syndrome, whether they're in a healthy population or whether they're looking after people with mental illness or intellectual disabilities, would refer back to this paper. This paper was published in 2009, and it's an internationally renowned because it has people from diabetes epidemiology, people people from heart foundations that came together and published what they mean by the core risk factors for metabolic syndrome. And again, there's five risk factors, and the risk factors are: the first one, central obesity, high blood sugars, hypertension, high triglycerides, and low good cholesterol, low HDL cholesterol. So they're saying 3, if the 3 elevated, or 3 out of parameters, risk factors, then the person will have metabolic syndrome. So that paper might be useful also to have a look at that and have a look at what we mean by the 5 risk factors and which 3 would be the ones that we'll be monitoring for them all. But having 3, if a patient comes back with 3 risk factors, then we know they fall into the category of metabolic syndrome. We know once they have been diagnosed with metabolic syndrome, that puts them in the high risk category for, obviously with all the comorbidities, for mortality, higher mortality than the general population. So we have to be cognizant of this paper being very important to us. In this paper, there is one discrepancy, and the discrepancy is about waist measurements. And I know a lot of you have now, I hope that a lot of you would be screening for waist circumference and that you would be using your tapes. And the tapes that we would be using for our Irish population, which we call white Caucasian, we would be setting the parameter of male waist circumference as being less than 102, and we will be centimeters, and we will be looking at a female waist circumference as being less than 88. However, the Alberti et al. Paper does say that we will have different waist measurements according to different populations, and they will always measure the Asian populations, Japanese, Chinese, sub-Saharan African populations, with a smaller measurement. So that might be important now as we're more culturally diverse in our nursing care, that if we had patients who are attending our services who may be from a different population, whether to be Asian or Japanese or Chinese or sub-Saharan, that we would take that into account, that the waist circumference may vary from what we would call our white Caucasian population to other populations. So just keep that in mind, and that's an important one to know. Okay, the next one I'm going to bring your attention to from regards evidence, because we do always kind of talk about best practice. So best practice for us, and this paper is published since 2009, but this paper was going on for many years, and it was looking at the Alberti et al. Position paper, and these people came together. It's a Dutch psychiatrist called De Hert, Mark De Hert is his name, and he came together with people from the European Psychiatric Association. He also involved the European Association of Diabetics to come to work with him, and the European Association of Cardiology. So he got all the best people together around the table, and he talked about the problem we have in people with severe mental illness and the high mortality rates. And he developed an algorithm, if you like, of sorts that looks at people with mental illness. And his paper is still very, very much used and out there because it gave a very good example of what we should be doing when we find what parameters we should be taking, obviously the 5 parameters, but also what we should be doing when we find that they're outside of risk factors that he's identified. So maybe perhaps that paper might be another one that you might be interested. If you need it, I can absolutely get it sent on to you. No problem at all. So back to what we're measuring here. This is our tool. Our tool will be a monitoring, and I call it a screening and a monitoring tool all in one, because the first thing you'll do is screen. The first time you take these measurements, you're screening. Every other time you go back, you're monitoring because you have a baseline. So screening is about getting baseline, and baseline means getting your waist circumference, getting your blood pressure, and also then working through the bloods, working through 2 different blood tests, sending off for fasting blood sugar and sending off for fasting cholesterol test. So there are measurements. So, what we need for that. We need somebody that has a tape measure for taking waist circumference. We need somebody that can take a blood pressure, and we need somebody that has phlebotomy training that can take 2 blood tests. And that's our baseline. And once we get our baseline, we'll know where our patient's at. We will determine by looking at the results of those 5 factors whether the patient has metabolic syndrome or not. Hopefully they won't. And then the next time time we measure, we're doing monitoring. We're monitoring again of what we found on the first occasion. So that's really our tool. There are tools out there. Maybe if you have a tool, or if you're already using a tool, you might share that in the chat box with us to say, yes, I'm using a metabolic monitoring tool. And does it contain those 5 criteria? That would be useful. So if you have a moment there, just think about your measuring tool, if you have one that you're using, and just chat into us and let us know. Is your screening tool used in your area where you work? And if it is, does it measure these 5 criteria? Because this is essential. Because if it doesn't, it's not measuring for metabolic syndrome. So we really need to know that, and we really need to know that your tool is evidence-based. Okay, so that's the most important thing. And if you have any questions about your tool, maybe share that with us as well. Okay. Anything coming in there, Sheila?
No, come
on, put it up to you now. We're not asleep. Wake me up in time. It's time to wake up.
The live event Q&A session, please. Because I can't believe nobody's screening.
Oh, okay.
There's nobody in yet, but we'll get to another slide and then we'll ask.
Yeah, we really need to know this, because, you know, I'm probably speaking to the converted here. But if I'm not, then we need to know, you know, what extra information you need from today. Okay. Waist circumference is what is the primary indicator for central obesity. Is one of the biggest things that Alberti mentioned in his paper, and the measurement of waist circumference is really important. And we've already said we're looking at different measurements for different populations, but I'm going here with the European Caucasian measurement, which would be a maximum of 102. Anything over that for men is considered high risk. Anything over 88 centimeters for women is considered high risk. Well, unfortunately, a lot of people don't get their waist circumference correct. So the waist circumference should be across the area of the belly button. So, you know, you're literally over the hips, but not in the narrowest part of the, I mean, a lot of us ladies would love to think that we'd measure our waist in the narrowest part of our body, but that's not a waist circumference. A waist circumference has to be right across the midline and across the belly button. So if you're unsure, I would advise you to just always check that the waist circumference is just at the level of the belly button when you're reading it. Is that okay? So that would be important. And then that you realise that if it's over 88 in a female, that would be considered, you know, out of normal parameters. Anything over is out of normal parameters. And unfortunately, most of our patients probably go down with this first measurement, which is waist circumference, because of the problem with, you know, obesity in our populations and with the amount of antipsychotics that people take. But, you know, this is our first measurement. Our second measurement is elevated blood pressure, and a lot of our patients are probably not always have their blood pressure taken, and they may well have hypertension, and it may well not be ever diagnosed. It's asymptomatic illness. It is often called the silent killer for that reason, in that the patient generally doesn't feel any adverse effects to having hypertension, and it may go on for years. And they may well not know it. If a blood pressure, however, reaches stage 2 hypertension, which would be somebody with 180 over 110, then we know they're in a medical emergency. You know, that's a hypertensive crisis at that stage. And we have taken blood pressures in our clinics of patients who would be at stage 1 and stage 2 hypertension. We regularly see patients with blood pressure of 160 over 100. It's not unusual for us to see that. And that would be considerably very, very worrisome to us, particularly if the patient isn't being medically controlled for it and hasn't been even with their GP. So, you know, we need to be kind of raising much more awareness about elevated blood pressures. The symptoms, the symptoms don't really come until the latter stages of the blood pressure. At the earlier stages, you don't see it, and it's so asymptomatic, but there are a few to watch out for, and patients need to be aware of. That headache that they might complain of that blurring across the back of the eyes. Some people, even with high blood pressure, complain of nausea or vomiting. So, you know, it's unusual. Complaints of maybe headaches, generally. Nosebleeds might be an indication of also elevated blood pressures. Or, you know, when it gets to the stage of the palpitations or feel their chest beating very hard, well, then we know there is something seriously wrong, and the breathlessness. So, you know, at that stage, we're looking at a serious hypertensive crisis. But we have patients who have undiagnosed high blood pressure, and the more blood pressures we take at nurses, the better, because we're getting baseline, you know, and we can return then. If a patient comes into our clinic and it's elevated, we should go back in 10 or 50 minutes and take it again, just to see, you know, was it just exertion to put up the blood pressure, or are they suffering from high blood pressure? Because this is one of the key indicators of cardiovascular problem and a disease of the heart. So we need to be monitoring that, and of course the risk of stroke. The next thing we look at is the triglycerides. When we take a fasting cholesterol, these are what we're interested in. We're not interested in the total cholesterol, we're interested in the measurements within that. So we're looking at triglycerides. We like to think that the triglycerides are kept low. So we're looking at normal level would be 1.7 mLs OLs. So we're trying to keep it down as low as possible. We will see people with much higher than that. We'll see borderlines, we'll even see very high triglycerides of over 6, but we know that the triglycerides are contributing, really a huge contributor to arteriosclerosis, thickening of the arteries, and therefore contributing to high blood pressure. So the triglycerides are just the way they contribute to the whole overall health of the patient is huge. You know, our aim for these would be to lower these with, you know, obviously diet, exercise, and maintaining a healthy body weight. But we do measure for triglycerides as an important indicator of vessel health, cardiovascular health, and it's one of the important measurements that we would take. The other one we would watch out for is looking for good cholesterol. We're not really, we don't really mind so much about low density lipotropins. We know they're there. People who have high cholesterol will also have high density lipotropins, but we're looking for good cholesterol here. So we want patients to have as much good cholesterol as possible. So we know the value of the good cholesterol, because the good cholesterol, the HDLs, are there to pick up all the bad cholesterol and carry it away to the liver when it's broken down and excreted. So watch out when the blood results come back to look for HDLs, and the HDLs measurements. There's a slight difference in the male HDL and the female. It's not a lot, but there's a little bit of a difference there, because females carry a little bit more fat maybe in the body than males in some cases. So we just want to pick up how much good cholesterol a person has. The more they have, the better for their overall health. Okay. And the last one is the fasting blood glucose. And because, Sheila, you have more expertise in diabetes than I'll ever have, maybe you just go through this one for me, please.
And particularly what I want to talk about, particularly in relation to this, when we talk about the normal, and it's something it's always like doing with students, we talk about the normal blood sugar and we talk about the diagnosis for diabetes blood sugar. And if you look at it, normal were 3.9 to 6. And that's one thing to remember, and I'll talk more about. 4 is the floor. I don't want anybody below 4 if they're will have diabetes. And then we talk about, if I'm diagnosed with diabetes, I do it on a fasting of 7 or greater, or random of 11 and greater. But the thing is, what I really want to focus on here is the pre-diabetes or impaired glucose tolerance. And this is something you sometimes see, and okay, they're not quite perfect, the result you get. Like, it's not below 6, so it's not perfect. But it's not above 7, so they don't actually have frank diabetes. And the thing is, it's now being recognized that this is what we call pre-diabetes or impaired glucose tolerance. Mm-hmm. And it's actually very, very important. People with pre-diabetes or impaired glucose tolerance are much more prone to developing cardiovascular disease, to developing diabetes, and indeed, you will find they have high insulin resistance. All factors which you will have heard Angela talk about in the metabolic syndrome. We have also found that if we intervene at this stage when people have impaired glucose tolerance, and if they become physically more active and lose a bit of weight, not easy things to do for some people, but if they can do that, they can prevent themselves developing diabetes or indeed developing complications. And it makes a huge, huge difference. To the extent there are now programs being run in some areas of the country to actually meet with people and educate them in relation to impaired glucose tolerance and what they can do to prevent it going further. And just think back on your patients or clients that you work with. How many of them might fall into that category and what's being done for it? And it's something that is very, very important, because it'll just prevent them getting ill. And this is back to the idea of screening. If I screen for diabetes, fine. If they have diabetes, they'll end up in the clinic. If I screen for diabetes and they're normal, they've normal blood sugars, that's fine. They don't end up with care or treatment. But if they're in that impaired glucose tolerance, what happens to them? Does anyone intervene? And unfortunately, quite often it's a case of, it's not quite perfect, we'll repeat it in a year. What we should be doing is going, let's educate them to what they can do about it. And people who have impaired glucose tolerance, and you see a number of factors which increase the risk of developing type 2 diabetes. These people will often present with impaired glucose tolerance before they present with frank diabetes. People who are overweight or obese, with the waist size, as I just talked about, greater than 88 for women or 102 centimeters for men. If people are physically inactive, and again, you think back to a lot of your clients and patients, partly to do with their medication, partly to do perhaps with their mental health, they are not that active. Can we encourage them to be a little more active? And I'm not talking about getting them out to run a marathon. We try and encourage our patients, even if it's only to walk to the gate and back twice a day or once a day, or walk to buy a paper, or walk a dog. And it's simple things, and it's something I'll talk more about again in the next sessions, setting achievable goals. If you have a first degree relative with type 2 diabetes, that's bad luck, but that's a fact of life. You are more likely to increase it, particularly when we look at parents or aunts and uncles or grandparents. If they have had type 2 diabetes, it means you're more likely to get it. So therefore, these are people I should be encouraging to be more active and such like. Obviously, high blood pressure and raised cholesterol levels. Well, I often say chicken or egg, but certainly it's a big issue with my patients. People of certain ethnic areas, South Asian, African, Caribbean, and indeed some South American Indian tribes, huge incidence of diabetes among those people. And you look at Ireland now, we're much more diverse and multicultural. So these are people who you're going to increasingly see in your clinic. So again, we need to be more conscious of this. Are they being screened? Are they being checked? And as Angela said, if they are we intervening? Yes, a higher incidence in relation to smoking, and that is a huge problem. We still have it among patients with mental health issues that they smoke, higher incidence of smoking. And unfortunately, we're not proactive enough in getting them to quit. There's no reason why we can't give them that option. And I often will talk about, if you really want a lovely example, when they brought in the smoking ban in 2008, which was countrywide, and there was exemptions for certain areas, one being mental health institutions at the time and the other being prisons. And the one place that didn't take the exemption as they could have was a central mental hospital in Dundrum. And they decided they wanted to move on it. And they started with an education program, and they actually brought it in there, and they found they had as much enthusiasm for the smoking cessation from their inmates as their patients there as they had from the staff, and indeed at times it appeared to be more. But they actually worked, and they brought in a smoke-free environment there at that stage, way ahead of it, because I know it did happen later than the mid-teens for the rest of the areas. So it's as I say, just because people have a mental health issue doesn't mean they don't want to give up smoking. Okay, they're like the rest of the population, not everybody will succeed, but a lot of them do want to try. And it's again that encouragement, even if you try and fall off the wagon this time, let's try again. And it's that encouragement, it's so important. We're back to this like education for the patients and letting them make decisions and giving them some sense of ownership of their health and responsibility for their health. And it makes our life easier as well, I will say that. So something I think we really need to focus on a bit. That is the WHO definition for diabetes and impaired glucose tolerance, by the way, and I will put that link up next week on my session for the diagnostic criteria with it. We'll get it from Angela this week.
Yeah, thanks, Sheila. That's good. Thank you. Okay, I'm wondering, have you any feedback to me there on whether people are using metabolic monitoring screening? Or...
Well, if they are, they're keeping very quiet about it, Angela.
Oh, okay.
Here in the Q&A session.
Okay, maybe is people able to log into it, I wonder? Well, yeah, I'd be hoping that, you know, you have something there to look at, because if you have a tool, that would be good. You know what metabolic syndrome is now. You know the high prevalence we have, and we know from listening to the last half an hour or an hour the importance of screening. Screening helps disease prevention. That's our big message. That screening is an important message, and screening isn't once-off screening for us isn't enough, because our clients change over time. So we would be looking at continuous monitoring for disease prevention. Okay, I would love to know, like, how many of you have nurse-led physical health screening clinics in your area, or how many of you have clinical nurse specialists working in this area. I would be advocating for more and more of this physical health screening, because I don't think it's good enough that if 60% of our population of clients can suffer from metabolic syndrome and die 20 years sooner than the general population. I would like to think that everybody would be able to live quite a long and active life up into their 80s. So I'd be thinking that this would be a huge thing for us to have more nurse-led monitoring clinics for our patients. Also, when I talked about screening, there's no use, as Sheila said, in screening if we don't intervene. And I mean, anybody that works in health promotion knows the importance of promoting healthy activities. And again, you know, we talk about that a lot, about smoking cessation, diet and exercise programs. We talk about the importance of that. When we open up the HSE physical health monitoring, I'm going to open up now in a few moments and look at it. Built into that will be ideas about smoking cessation and where you can get help, and about diet programs and exercise programs. So, you know, we will be looking at that now in a moment. We'll also talk over the next, not maybe next week, but certainly by the 9th of December, I'm going to talk about who is responsible and how it can be implemented. So we're looking at more coordination between our GPs, our primary care for people, to look at, you know, our how many of our clients are on medication for high blood pressure, or maybe on Lipitor, or maybe on metformin. You know, a lot of this information is lost between primary and secondary care providers. So we need much better coordination between primary and secondary care. So I'm going to be saying, you know, we need to be challenged on that one. You know, it's we're going to challenge a lot of things around the area of physical healthcare, but that would be one of the areas that we will be challenging. Maybe already some of you out there already got a very good system going between primary and secondary care with your GPs and your psychiatrists or your psychiatric teams. If you have, you know, maybe share that with us as to how it works for you. We don't have a lot of publications in this area. We've actually no publications at all from Ireland on how this whole area is working. A little bit of maybe better in the UK, because in the UK a lot of psychiatric care is delivered in primary care through, you know, to get a lot of depots, and they get a lot of medications from their GPs in the UK. We have certainly a different service here, so we need to kind of look at what would be best practice in our service and how we could, you know, move that forward. I'm just going to stop this slide for a moment because I want to share something else with you, if you don't mind. So is that okay? I'm just going to close that one, and I want to open up another document that I have here on my desktop. Cancel that, sorry. Okay, are you with me there, everybody? I'm closing that. Yeah, I'm coming back to you now. I'm going to open a different one now. I want to open up, if I can find it, just a second now, forgive me.
It's one thing I would like to say as well. Bear in mind, I'd love to change everything tomorrow. I'd love to have a magic wand and be able to make everything better tomorrow. Life doesn't work like that.
No.
But think about what you're doing. If you can go back to practice and make a difference to even one patient, think how much that would be. And bear that in mind. We always have to start with small steps. And if you can just go back and talk or think about it, you know, when did we last offer something about healthy eating or something about quit smoking in your practice?
Yeah.
If it's only just a few leaflets or a small talk, just something simple. And if it makes a difference to one, that's a good start. And keep that in mind. As I say, you're not going to change the world overnight, much as we'd like to, but it would be a a nice one step here. I'll hand back to Angela there because she has it open now.
Yeah, I have the HSE document. The HSE have published this in the last year for us. It's physical health support for people in mental health services. And they actually, I know that this form is being used in North County Dublin because I've some interaction with the North County Dublin team out there. And, you know, I think it's useful maybe to have a look at this. It's the physical health assessment form on admission, and maybe a lot of you might not be familiar with this, but the inpatient units now are currently using this form. Would anybody be able to feed into the Q&A box whether you're familiar with this form or whether you're currently using it in your inpatient services? That would be useful. Sheila, keep an eye there.
Yeah,
so
nothing in yet, but I'm sure.
I don't know if that chat box is operating really well, but look, it's a 5-page document. It's a multidisciplinary document. Obviously, when the patient's admitted, there will be a medical registrar who will probably start the first couple of pages of the document. So the first 1 to 2 pages is like what we would do when any patient's full medical. So they'll do respiratory, they'll do the abdomen, they'll do the neuro, and they'll do the cardiovascular, and then they'll order whatever bloods they feel is needed, and, you know, ask some things about physical health and family history, and, you know, do a full assessment of, you know, anything abnormal to do with the patient. But then it moves on into page 3, 4 and 5, and this is more or less stuff that anybody on the nursing team can do in collaboration with the patient, and it's basically exactly what Sheila said. It's screening for chronic illnesses or screening down the road, and it has the national screening programs built into it, and they're the ones that Sheila mentioned to you: the bowel screen, the cervical screen, the breast screen, and the diabetic retinal screening for anyone that has been diagnosed with type 1 or type 2 diabetes. So that's very important information for us to have. If they haven't taken place, if no is the answer, it gives you the free phone number. So, you know, you're immediately being proactive there with your health promotion. It looks at GP visits, dental visits and optical appointments. So it gives you a very good indication of how much interaction your client is having in primary care. This is hugely important. You know, to have this information means, you know, you can do so much if they haven't had a recent visit to either their dentist or their their eyesight test, that they can go for it. It even looks into sexual health and sleep problems with the patient, and it'll go into depth about that, how many hours sleep and so on they're getting. And then we move on to the MEC, what we call the MEC training. And the MEC is very much interested in having that conversation with the client. And it starts off with the tobacco use, if they're a smoker, and how long they've been smoking, and if they've tried to give up smoking. And it gives you signposts there for HSE websites for the quick smoking, and lots of advice there on what you can do. It then moves on to the alcohol screen, and it even gives you a short screening tool there to assess alcohol screen in your patient. And it gives you an intervention of what you might do, you know, the interventions for alcohol, anybody that comes up on an alcohol screen. So there's lots there that can be useful to you on an everyday basis on alcohol screening and on smoking. Then it moves on into weight, and it looks at, it does a BMI. Anyone with a BMI of over 30 would be considered obese. You know, we're overweight at a BMI of 25, but the risk factor for us when we're looking at metabolic syndrome would be people with a BMI of over 30. So if you already haven't got this in their chart, this is a great place to capture it on admission. So it kind of feeds into your metabolic screening tool, if you like, because this information is invaluable to know what the person's weight is on admission: underweight, healthy weight, or overweight or obese. And it kind of gives you a little bit of idea of whether they'll work with a brief intervention or whether they won't, or whether they'll become involved or not. So you have lots of little tick boxes there to help you in your conversation, which is part of what you would do. And as well as
with great feedback now, there is some people have a tool, some people have a self-devised tool, and some have none at all. There's just, they have to wait for a multidisciplinary team agreement before they actually use it. Another one there who said their clinic is in the afternoon, they're wondering if there's any benefit in doing fasting, or when they can't do fasting glucose or that or cholesterol. I would say yes, there is benefit. First of all, if you can't do fasting glucose, we would recommend you do a HbA1c, glycosylated hemoglobin, which will give you an indication of the blood glucose for the past 4 to 6 weeks. It should be below 48 if people don't have diabetes, if they have normal blood glucose. If it's been elevated, you will find a raised level. in relation to the cholesterol triglycerides, yes, I would even take a random one. If either the HbA1c or the cholesterol triglycerides are abnormal, then it's worth getting the patient in for a fasting one. But it will give you a good indication of where to go with it. And I say you may be doing other bloods for monitoring anyway for drug levels. So I would certainly say yes, even if it's the afternoon, I would sooner have a random as a checkup rather than have nothing at all. And as I say, then if it's normal, fine. You don't need to be active in that area. You can just focus on perhaps smoking or healthy eating or whatever. But if it is abnormal, then it merits further investigation with it. So that's it. I'm the multidisciplinary team, Angela, just curious about that.
Getting it passed by the multidisciplinary team. The only way I would encourage you to do that would be to go with best practice. Psychiatrists, any doctor, any medical person I know will never disagree with best practice. So once you produce the evidence, I always say you cannot go to a team and look for something where you have evidence. So the evidence for you would be the Alberti et al. Paper, which is the harmonizing statement that claims you have to have these 5 parameters measured, and also the algorithm that's provided by Mark de Hert and colleagues in Europe. So there are the 2 key papers that evidence you need to go to your multidisciplinary meeting and say the evidence is here, this is what we should be doing. It produces, you can get 100 papers if you want to back up why people are doing this. They're doing it internationally around the world. We've been auditing services now for many years, and we've been finding high rates of metabolic syndrome, up to 60% in some clinic areas. So the rationale for doing this, there's no other way. There is a rationale. They can't say no, we're not doing it, because the very minute you provide the basis of why you should be doing it, then people will agree and say, yes, this is important. You know, no doctor in the right mind would say, no, don't do this, let the patients die. Nobody will ever do that. You know, everybody wants to promote health and wellness. You know, I think it's just getting collaboration together on which tool you're going to use. I'd love if we had a standardized tool in Ireland that everyone would be using. You know, a lot of people are making up their own. I don't mind you making up your own as long as it has the 5 criteria in it. As long as it does waist circumference, blood pressure, and the 3 bloods. And the 3 bloods are fasting blood glucose and your cholesterol tests, your 2 cholesterol tests, one for triglycerides and one for good cholesterol, high density lipotropins. If that's included in your tool, then you're right. You have the measurement, because that measurements then, once they come back, you need to sit down and look at your blood results, look at your waist circumference, and look at your blood pressure. And if more than 3 of them are abnormal, not fitting into the parameters that they should be fitting, then you can easily put a red dot on that chart and say that patient has metabolic syndrome. And the next question is, what are we going to do about it? And that's where we come in with all of our strategies, which we look at next week, which are related to how you look after a chronic illness. Sheila, you've just mentioned how to look after a chronic illness. You know, it's all going to be health promotion, but we can prevent education. Yeah, we can prevent these deaths. We know we can turn it around. Dr. Mina in DCU, he's one of the people that work in health and fitness over there. He's constantly doing education programs, rehab programs for people who have type 2 diabetes, for people who have respiratory illnesses, and he's actually returning them back to wellness again. But they're following a very structured regime on, you know, how to look after physical health, you know, but there's evidence there that they work. The literature is full of evidence on the benefits, and we'll show you them next week, on the benefits of brief interventions. And, you know, even this brief intervention like making every contact count, coming up every time and saying, have you thought about this, or have you worked with this? And, you know, we're MEC trained ourselves, so we know the benefit of having these interactions with our client and how it can, you know, if we find, and remember we said earlier, it's not fatalistic. The client wants to do something about it. Nobody wants a BMI of 35 or 40. Those clients really struggle with that, and they struggle maybe with respiratory distress because of it, and, you know, high blood pressure as well. So they don't want to live that life. They want help, you know, and it's wrong to say they're not interested. It's wrong to say that. We have to, you know, think that, you know, we're starting here to challenge those beliefs that are fatalistic, that there's nothing we can do. We're challenging all that. We're turning that on its head, and we're challenging this diagnostic overshadowing to say, oh, that's just part of their mental condition. It's not, you know. So from that point of view, these kind of things these days help us to think about what we can do, you know, and if we don't have a tool, we can develop a tool. I prefer if you use the best practice ones, which are already outlined in the literature, and maybe, you know, if you can take this document and look at it and present this to your team as well and say, look, this is produced specifically for mental health services, and it's one that's used on admission, but it also has a lot of useful, especially page 3, 4 and 5, of useful data there that we could use with our clients. You know, we could print off the last 3 pages and use them.
Someone has asked that, does anyone have a simple tool that could be used in a long stay residential area? And I would agree with Angela, have a look at this. I know it says on admission, but basically these are things we should be checking regularly. Like, we do what we call an annual review on people with diabetes, and every year we check their diabetes control and how they're managing it, how well they're managing it, and we check for complications. If they don't have any issues, that's great. If they do, we'll then follow up on that. So maybe their blood pressure is up, we'll chase up on that, check it more often, perhaps start medication. And the same applies, even if you're talking about a long stay residential unit. What's wrong with doing something like this? Maybe, Angela will shoot me for saying this, maybe if you feel there's too much in it, just simplify it, but keep your main 5 points definitely have to be checked every year. Keep those in it and do it every year, just to have a routine check with it. And as I say, the other thing we have to remember, you know, as I say, it's very easy to be enthusiastic at the start, but we all tend to fall off the wagon. And if you have a chronic disease, or if you have a chronic condition such as being overweight or things like that, it's very hard, very easy to get fed up and sort of say, God, I really can't, I'm giving up on this. And we have to bear that in mind. People are allowed to have those days. We all have those days. And it doesn't mean they don't want to start again. Maybe next week might be another time period. So it's something we have to be conscious of to try and keep people motivated. The other thing we've always found is with any chronic disease is education. When you look at how much information we've thrown at you today, if you retain 10% of it, you're doing well. It's going to be the same in relation to what your chronic illness as well, such as your metabolic syndrome. I'll tell you all these things about minding your blood pressure and making sure you stay active and all this. If the client or patient remembers half of that in 6 months' time, they're doing very well. So it's up to us to constantly re-educate and emphasize the important points with it. And that's something we need to remind ourselves to do, I think, at times. Sorry, Angela.
Yeah, no. I can just completely reiterate the very same as you've said. I do believe we need to be very organised with our screening and our monitoring. We need to be following up on clients. We need to be promoting health. Again, I can't emphasise the importance of coordinating with GPs and primary care providers, because you're right, Sheila, we need to talk to each other. You were a diabetic specialist for years, but you never met the mental health team in your life. So, you know, we need to be talking to each other as to, you know, your expertise needs to be shared with us so that we can provide better care for our diabetic patients, and we know we have many of them. So, you know, it's even, you know, knowing how many diabetic patients maybe you have on your caseload, that might be a start for a lot of, you know, nurses, you know, to know, you know, exactly who are they, and then maybe what can I provide for them, you know, maybe looking at individual work with them or group work with them. But certainly, you know, if you can even start there by knowing who your patients, who's the risky ones, and what can I do for them? That's a place I would start anyway. I think if I was working out there in clinical practice, that's what I would be doing. Any more feedback?
No, as I say, I find it interesting that there is so many using the form, which is very reassuring. And for those who don't, I'd say, you know, as Angela says, best practice. Why not introduce it as something? And I know this is a time when, let's be honest, we all have other things on our minds, such as social distancing, and we're going to be looking at vaccine regimes, and you guys will probably be involved in that to some extent. So why not introduce an assessment even at that stage, because you will be seeing your clients for, you know, for vaccination, I hope, in the next 6 months. So, you know, it's not something, it's something we need to start as soon as possible. I would say, if you don't have it, well done, and congratulations to everybody who's doing it. And I hope there are good interventions coming from the information you're getting. But as Angela says, it doesn't matter that there's, while it'd be lovely to have a standardized one, it doesn't matter that there's shared one. One thing I would say is, have you shared that information of what you're doing and how it's working with anybody else? And that's where even giving a talk in the local, at your own local area, practice development and things like that, it can be very, very useful. You learn far more from each other. Yeah, and you can learn a huge amount, and I think it would be very, very important. And I see somebody's even got a dietitian, but they're not out in the community yet. But it is nice to see. We do have a few community dietitians, and that's something to remember. You mightn't get them easily for your clients, but if your patient is diagnosed with diabetes, then they might have better access to the community dietitian. So I know we shouldn't have to do it, but there's sometimes we have to go, sort of use a bit of lateral thinking to get access for our clients to the services they are entitled to or deserve and need. So it's something to bear in mind. Thank you, Sheila. Okay, I mean, I'd love more interaction from you, and I'd love to be able to talk to you and take your questions individually. But our format at the moment now is restrictive. But if you can come back to us on the next week, on the 2nd of December, which is Wednesday of next week, Wednesday morning, 11 to 12:30, and if you can think about what we've just said, and maybe you might be able to send some questions on in advance, or have something ready for us on the morning that you can type in, that would be great, because that would feed into where we're at with all this. But we will certainly spend much more time on managing this chronic disease, which is metabolic syndrome, and also I guess our big problem is managing diabetes. Angela, there's just one last question before you finish up as well, and they're asking why the Mental Health Commission doesn't make the screening tool available for community services. Yeah, well, Regulation 19, the JSF Regulation 19 is there for us to use, and a lot of people are using that as part of their audit tool when they go, like that Susan, Mental Health Commission Inspector Finnerty, she did a report last year on the hostels that she visited, and she found huge discrepancies in how they were being monitored in the hostels. And a hostel is, the patient can't escape from you, basically. If you can't provide physical health care to a patient who's living in a house and you're there 24 hours, it doesn't augur well for the rest of society, particularly for our community areas. So she did look at hostel provision of physical health care, and she was very disappointed with what she found last year. And I look at the Mental Health Commission reports regularly, and I do look at areas of compliancy, and therapeutic programs often come up as being poor, but also the physical health area often goes down, as do ICPs. So if your Regulation 15 isn't good and your Regulation 19 isn't met, well then we're not providing the care that the Mental Health Commission would expect. So we're failing in some ways. But the Mental Health Commission haven't given us a metabolic monitoring tool as such, but we know that best practice internationally has, but they have provided us with Regulation 19, which I might pull it up next week and we look at specifically what they expect from us in Regulation 19. And when you're doing your audits of your services, you can pick that one up and use it to monitor what's going on in your service areas as regards physical health care, or what your provision is like, and I think more and more now we're going to see this played out more in our services, particularly as the emphasis now is on, service users, empowerment and all this recovery focus. It has to be around physical health as well. We're not just looking after minds. We don't just cut the head off and say, I'm only minding the head, forget the body. We can't do that. We would never do that. So, we more and more begin to focus back on physical health care, particularly if patients say that the weight gain was due to the antipsychotic medication or the lack of therapeutic programs, and then we're completely going to have to put hands up in the air and say, yeah, it is our fault. We haven't provided you with what you need, and that's why health promotion is such a big part of every nurse's job. It's something we teach first years, the importance of health promotion, that, that is a big part of your role, as is advocating for your client. So I would say, do your health promotion and advocate for your client, and by advocating, if you have a client who's put on 2 stone weight in a matter of 6 months, there's something wrong there. Something has to be said and done about that, and you're advocating on their behalf. If they're not able to speak, I would encourage
encourage them to give them their voice as well, you know, to let the patient speak and say, this is what patients are saying, this is what they need, and this is what they want, you know. So in that way, then things can happen. We can push it up the chain, up to the whoever's sitting on the hierarchy of your multidisciplinary team. You know, you can push things up that direction, you know, and you can get things done. Things can happen by starting small and being pushed up the chain. That's how nurses are so good at doing that. You know, we know how to activate and to agitate a little, you know, and we've learned that over the years, that we can get things done. And, you know, this is how you could activate and agitate to bring about change, you know. And even though you don't have a specific tool, you can use what's out there. You can use it as best practice and say, well, every other country in the developed world are using these tools, so I think we should too, you know. Or else take up the Regulation 19 and look at it and say, see, what does Susan expect when Dr. Susan comes to visit with her Mental Health Commission colleagues? What are they going to be looking for in the patient's notes around physical health care? Yeah, would that answer the question?
I hope so.
You think we're good agitators, Sheila? We get things done?
We're getting there, Angela. It takes a few years of experience. I want to particularly thank Sinead for agreeing with me about the HbA1c and the random lipids. And the other thing, which Maria comments, that she found the brief intervention, smoking cessation, reduced therapeutic fatalism. And that's just an example of how things can work on the ground. And as I say, if you just make a difference to one patient, and I know you make a difference to a lot more, but if just think of how good that is and the work it is. But I must say, thank you for your interactions, everybody.
Thank you.
Somebody here is also asking, is there any benefit in doing a fasting blood glucose and a HbA1c together as a routine? There's a slight benefit, you know, it is interesting from point of view of treatment. If I have a raised fasting glucose and I raised HbA1c, it will tell me that something. If I have a normal fasting glucose but I raised HbA1c, then I still have to go for further investigation. But doing the two of them together, the fasting glucose is relatively cheap. I don't mind having it. It's a useful tool for me to have. It will dictate my treatment plan to some extent. So if I have it when I first see the patient, it's useful, but not essential. Other than that, and as I say, there's been lovely input now from us.
Thank you.
I would say thank you very much to all those who did that. It's been great to hear from you.
Yeah.
Ladies, thank you so much. That was I'm inspired myself, and I see Lynn there says, many thanks, I feel enthused. So do I must take my own. You know, you have us all thinking, even for ourselves and our own. Yes, my BMI might be a bit higher than it should be too. So even after listening to you, I feel enthusiastic now, and we have to take things into our own hands. That was amazing. I'm just going to give, in case there's another question or two, just you were able to read them there, Sheila, just in case there's anybody with any burning issues. But I'm delighted they've told you they'll be back. We have 2 more weeks with Sheila and Angela. So next week on the 2nd of December, so next Wednesday from 11 to 12:30, factors related to chronic disease, mental health and diabetes. And as Angela said there, if any of you want to send in questions, please send them in to Anya and we will collate them ahead. If that helps, we're more than happy to do that. Just put on the subject of your email Wednesday the 2nd of December session, and we'll do that. And then the following Wednesday, taking us right up to mid-December, on the 9th of December from 2 to 3:30, we have physical health screening for people with mental illness. What is it, how it can help, and how it can be implemented. So really, really, hopefully those will be of interest to you. There was 49 people on for the duration, so that's brilliant numbers. And as you said, lots of engagement. And actually having 2 presenters was really lovely, because just your interaction too was very different for us listening. No, but that's really not, you know, it just breaks it up. And again, you have somebody to bounce your thoughts off. So I thought that was really certainly something for us to consider too. It just is lovely, I think, for an attendee. So if there's no further questions, we're just on time. Thank you all for attending. Thank you all for your interactivity and popping in your questions. Thank you particularly to Angela and Sheila, who were here to share their knowledge. And as you can see, they have extensive and comprehensive knowledge and experience, and that really shines through. So we're delighted to have such wonderful people obviously supporting us on with these webinars. So without further ado, we will see you all next Wednesday. Tell your friends. So we expect more now next. We're putting it out there. We'll be looking for 100. If everybody gets another friend, we could get to 100, and myself and Anya, we could break records, Anya, couldn't we? We'd be recording the numbers, so when we always hit a new record, we'd be thrilled. So we're putting that out there now for next week. So we'll see you back next Wednesday, 11 o'clock. Factors related to chronic disease, mental health, and diabetes. And I hope you all have a lovely, good week. Stay safe, and we will see you next week. Thank you, everybody.
Thank you.
Thank you, Catherine.